Welcome everyone to our second In Touch with Experts series of May. My name is Jamila Jackson. I am the founder of Kangaroo Care Day and Nurtured by Design. And for those that know the Zaki, that is our brand, our company, and that is because my son's name is Zachary and his birthday is May 15th. With this initiative of the In Touch with Experts, we want to bring evidence-based topics in plain English to families that are hospitalized and the clinicians that care for them. I also want to thank the organizations that collaborate with us, that are parent organizations, and I want to introduce Dr. Agnes Linnér, a neonatologist of Karolinska University Hospital and a doctoral student at Karolinska Institutet of Stockholm in Sweden. Her research interest is global neonatology and more specifically the potential of early skin-to-skin contact or kangaroo mother care. In June 10, she will be graduating and she will defend a thesis entitled Immediate Skin-to-Skin Contact for Very Preterm Infants from Newborn Psychology to Mortality Reduction. I am going to let you share your screen and please welcome.
Thanks. So thank you very much, Jamil. It's an honor to be here with you today between Dr. Provenzi and Dorothy to talk about kangaroo care as I know it. So as Jamil said, I'm a neonatologist working in Stockholm. So I'm working as a clinician consultant in the Karolinska University Hospital in the neonatal units here. And I'm also a doctoral student with a research interest in skin-to-skin contact integrated in the NICU care, and also in skin-to-skin contact in low and middle income settings. So basically my research interests are global newborn health and developmental origins of health and disease. So for those of you who listened in to Dr. Provenzi last week, you will know a lot about epigenetics and the impact of the early environment. And I guess these two research interests, they actually converge in kangaroo mother care, and that's why I'm so interested in this topic. So the outline of my talk today, I'm not going to talk for long because I think we need some time for discussions, but I'll start with what we do know about skin-to-skin contact and why this is so important. And I think for you this will be no news because you're here today because you have already understood the importance of skin-to-skin contact or kangaroo mother care. I will also stay a bit with the knowledge gap because that's where my research is. And as Jamil said, I'm in the middle of preparing for my dissertation, so I'm a bit focused on that topic at the moment. Then I read what the participants had wished for as topics. So I will try to give some good examples from the Swedish NICU, some pictures from Stina Klemming and myself, and some examples of how to integrate skin-to-skin contact to the NICU care. So that's the outline for today. So first of all, let me see if I can. So first I will stay a bit with the global health issue. So the thing is that globally, the decrease in newborn mortality is very slow. So while under 5 child mortality is decreasing nicely, then newborn deaths doesn't seem to be important. I'm sounding a bit cynical there, but I think that newborn health is not a top priority in the world, unfortunately. The current newborn mortality rate is, or at least in 2020, it was 17 per 1,000 live born. And this compared to Sweden, where the newborn mortality rate is 1.4 per 1,000 live born. So it's really different between settings. Also knowing that 15% of all infants are born low birth weight or preterm, and obviously they will have a much higher, tenfold higher mortality rate than their term equivalents. And we also know that 75% of newborn deaths could have been prevented without intensive care. So it doesn't take fancy NICUs or equipment or technique to save the majority of newborn lives. Simple things, one of which we will come to shortly. Also, 2/3 of newborn deaths, they occur early. So during the first 3 days is the most dangerous time period for a low birth weight and any newborn child in terms of not surviving. So knowing these things, Kangaroo Mother Care is known to be one of the handful of simple, it's not simple, but of the cost-effective, non-intensive care interventions to really have a high impact on the newborn survival. And until now, Kangaroo Mother Care was quite well used in the world. I think in most parts of the world, there are Kangaroo Mother Care units used as sort of step-down units. So Kangaroo Mother Care, I think, is very rarely integrated in the NICU care, but used for stable babies before they can be transferred home. So more for feeding and growing and becoming bigger enough to be sent home. But remembering that most infants die earlier, then many infants will never get the opportunity of having skin-to-skin contact because they will die already before getting the chance. And I think most of you will know of this article that was published about a year ago now. So the WHO Immediate Kangaroo Mother Care study group conducted a large trial in 5 low and lower middle resource settings, seeing what Kangaroo Mother Care initiated immediately after birth and integrated in the NICU care, what the potential was. And we actually found, I'm saying we because I was a member of this research group, we actually found that with immediate Kangaroo Mother Care, we can decrease the mortality with another 25%, and that's another 25% compared to initiation as we know it, pre-discharge. So this will be a game changer, I think, in the world, that we know that Kangaroo Mother Care integrated in the NICU care can save lives. This is a picture of my thesis. So I would like just to invite you to contact me on LinkedIn or ResearchGate or by email. This is my email address because I'm just wrapping up my thesis, which is about exactly this, immediate Kangaroo Mother Care and the impact of not waiting for the child to become stable, but rather to use skin-to-skin contact to make the child stable. And in this thesis, I've summarized the background about skin-to-skin contact care and especially immediately after birth, with emphasis on thermal control and cardiorespiratory stability during skin-to-skin contact. And also the New England Journal of Medicine article is there and some other things. So please do contact me if you want a link or an actual paper copy of this, because the knowledge gap is immediate onset or immediate initiation of Kangaroo Mother Care in the unstable child with medical equipment. And that's my research interest. So a little bit about how we use skin-to-skin contact or Kangaroo Mother Care where I work. I'm not saying this is how it should be, but at least it's an example from where I work. So for term infants, we start immediately. Term infants, they are always put skin-to-skin immediately after birth, and we have lots of projects about seroseparation after C-sections and so forth. So that's not controversial at all. For critically ill term infants, then it depends. So it's a day-to-day, hour-to-hour judgment of what the child can tolerate. But it's a priority. It's on the top of the doctors and nurses' mind to start skin-to-skin contact as soon as possible. And We do a lot of skin-to-skin contact, even with invasive ventilatory support, even with jet ventilation. For extremely preterm infants, then usually for 25 to 27 weekers, we wait a couple of days to a week until we start skin-to-skin contact. Remember that what I'm saying now this is our guidelines, and then I will come to how I think they should be changed actually. So our guidelines, they suggest wait a few days to a week before initiating skin-to-skin contact. For the really tiny ones, in Sweden we have active care, we consider active care from 22 weeks, so we have some really, really tiny infants in our settings. So for the 22, 23, 24 weekers, we usually keep them in the incubator for the first 2 to 3 weeks before we start skin-to-skin contact, according to our guidelines. For the very preterm infants, those born between 28 and 31 weeks, and that's my particular research interest, for them, we usually start during the first days. And for moderately preterm infants, it's recommended that they also get immediate skin-to-skin contact. And we have mobile equipment for starting them on CPAP in the birth room and transporting them in skin-to-skin contact with the parent to the NICU. So those are the guidelines. I don't know how you feel about them. We can discuss that later if you think that they are not so brave after all. I mean, now you are coming to hear me talk about the amazing care at Karolinska, and this may not seem so amazing after all, but these are our guidelines. But in reality, it's really individual, so it's different from one child to the other. So the doctor and the nurse decide together when to start skin-to-skin contact, and it depends a lot about the skin maturity. So whether the skin is mature enough not to lose large amounts of humidity and temperature, and also the skin quality. We don't want the child to be in pain because we're moving him or her back and forth. But it's also a question of if the child is ready, how well the infant copes with the procedures and nursing care in the incubator. So if an infant has a hard time coping with even a diaper change or position change, then well, maybe skin-to-skin contact would be beneficial, but the transfer from the incubator to the parent would maybe be too stressful after all. So those are the things we consider when initiating skin-to-skin contact. There are no weight limits, medical equipment, contraindications or such in our setting. Hypothermia and therapeutic hypothermia, of course, for term infants would be a contraindication for actual skin-to-skin contact, but we let the parents hold those infants with the hypothermia treatment on, so that would be a relative contraindication. So this is real data. We have a quality register in Sweden called the Swedish Neonatal Quality Register, or the SNQ. And skin-to-skin contact data is actually reported prospectively on a daily basis to this register. The variables that are reported to the SNQ are skin-to-skin contact initiation time, so the first time the child was in skin-to-skin contact with the parent, and then daily skin-to-skin contact durations, day by day. And this graph shows time to first skin-to-skin contact by gestational week. So you can see how each of the weeks from 22 to 31 weeks have different colors. And on the y-axis, it's the proportion of infants who have had skin-to-skin contact. So the 0.5 number there on the y-axis would correspond to the median time to first skin-to-skin contact. And you see how all gestational ages eventually will get skin-to-skin contact. On the x-axis, you will see the time from birth, so the postnatal hours from birth. This picture basically shows that for the 28, 29, 30, 31 weekers, according to the register, we initiate skin-to-skin contact on a median the first day before 24 hours. For the see now 25, 26, 27 weekers, a bit later, from the second to the third day, something like that. And for the 22 to 24 weekers, quite late, after almost a week there. But you should remember that these data are not validated, so it could be that some infants have initiated skin-to-skin contact earlier, but that it hasn't been properly documented. But I think, according to my experience, I think these numbers are a good description of the reality in Sweden at the moment. Maybe you've seen these two very nice publications. I think immediate skin-to-skin contact needs a systems change. Dr. Klemming with colleagues has written a very nice mini review last year about mother-newborn couplet care. And I think mother-newborn couplet care is a prerequisite for the very immediate skin-to-skin contact, because in most cases, when a preterm infant is born, then the mother will have health issues herself and be a patient herself. And it's really good if the mother and the infant can receive their care in the same place. Otherwise, we will not have much immediate skin-to-skin contact if the mother is not allowed in the NICU, for example. Of course, some paternal skin-to-skin contact, but the hours will not be very long because the father will have to come and go between his wife and the child, and possibly also siblings at home. So this mini review by Stina, Siri and Björn describes the challenges and some good examples from Sweden, and some concepts that's really interesting for those of you who are thinking about establishing mother and newborn couplet care units at home where you work. The second reference is a description of the experience in New Delhi after the immediate Kangaroo Mother Care study. Remember the multi-center study that showed a decrease in mortality with immediate Kangaroo Mother Care? So Dr. Chelani with colleagues have described their experience, and they were so amazed by just the concept of mother newborn care units. What happens to the mother and what happens to the infant if they can be cared for together from start. So skin-to-skin contact is of course important, but it's the whole concept of mother NICUs that I think will be the thing in obstetric and newborn care the upcoming years. Moving on now to just some pictures, some practical examples from Scandinavia, just to show you how we do skin-to-skin contact with medical equipment. So this is a picture from Ann-Sofie Ingman, who's a NICU professional with us. So this is a small, probably extremely preterm infant with the CPAP. So you can see how our CPAP systems are quite skin-to-skin contact friendly, I would say. I mean, at least compared to the NICUs I've worked in low and lower middle income settings, then the tubings are quite big, and skin-to-skin contact is not always super easy, but these are the interfaces that we have in Sweden. So CPAP would never be a problem for us in terms of skin-to-skin contact and feasibility. This next picture shows skin-to-skin contact during ventilator care. So you can see that that's neither a limitation or a contraindication for us in our setting. At Karolinska, where I work, most of our infants on ventilator care have a nasal endotracheal tube, because that's safer in terms of tube displacement. I think oral endotracheal tubes, they are a bit more at risk of dislocating when you transfer the child from the incubator to the skin to the chest of the parent. So we always make sure before transferring the child that the tube is securely attached, and of course, and this goes for CPAP care too, that we can reach from the incubator to the parent, that all the tubes and lines will reach where we are going. This is a picture of a brand new growth restricted 29-weeker. So I don't know if you can see, but he's just born a couple of hours ago. This child was included in a trial that Stina and I and a couple of other colleagues conducted in Stockholm that was just published in Acta Pediatrica a couple of weeks ago. So in this trial, we randomized very preterm infants to either immediate skin-to-skin contact with the parent or to conventional care, which meant incubator care first and skin-to-skin contact initiated later. And this was our premier skin-to-skin contact baby, Ville. You can see how he's just born. He's all red and new from birth, and he's stable on a CPAP, and he has, I don't know if you can see that he has an umbilical catheter there coming from underneath his wool blanket. So he's in a lateral position with his mother in skin-to-skin contact the first hours after birth, and he's so stable and the mother is so confident. So for these babies with newly placed umbilical catheters, then we usually put them in this lateral position so that we can visualize the cord and make sure that there's no hemorrhage. Whenever the umbilical line has been there for a while, then we also allow sternum to sternum skin-to-skin contact, because then we are not that afraid of hemorrhages any longer. The next picture was taken by Stina Klemming, and this shows a very preterm baby who's in skin-to-skin contact with the mother with a CPAP. And I think also you can see an umbilical line coming up there from the umbilicus. You can see how we do venipuncture in skin-to-skin contact. I think many of you do this too, but sometimes for the nurse it's a bit tricky to visualize and get in a good position. But I think with good training, good light, and good chairs, this can be a really helpful thing for the baby, because the procedure will be so much easier to tolerate with contact with the mother during the venipuncture. Lots of pictures from Stina Klemming here. I think here I forgot to write your name, Stina, but these are pictures also from the study I mentioned, the EPISTOS trial. So this is a 28-weeker who is just born. You can see the pictures from 1 to 4, how the baby is born, placed. This is actually the aunt who was used as a surrogate because the mother had a cesarean section. So the aunt receives this 28-week baby boy, skin-to-skin contact immediately after birth. And a towel is used to dry and keep him warm. You can see there on the third picture how a nasal CPAP prong is placed, and on the fourth picture how ECG electrodes are monitored on the back of the baby. So this is how we manage the super immediate skin-to-skin contact with the very preterm infants within this study. And hopefully this will be our routine when we've implemented the intervention type of care that we tried in this study. This is another a bit more mature baby boy. I think he was born at 32 weeks. This was a vaginal birth, and he was also immediately placed in skin-to-skin contact with his mother. And all the initial procedures were done there in skin-to-skin contact. So see how he is kept warm with warm blankets, and how a CPAP is placed there, actually on the mother's chest immediately after birth. I don't know if you've read, I think you can correct me if I'm wrong, Stina, but this couple have written about their experience in the NIDCAP magazine a couple of months ago, how they stayed with their boy for the first days in life, actually, without any separation at all. And this is another picture taken by Stina Klemming, who's a really good photographer. So these are twins born at 32 weeks, also within this study that I mentioned before. How you can family and infant center the care from start by having this mobile equipment that you can actually take to the birth room, so that you don't have to take the babies out from the parents to do the medical things. You can actually do whatever you need to stabilize the babies skin to skin with the parents. You can see here is the mother in front with one of the twins, and she's holding a cup with colostrum in her left hand, and she has one of the twins with a CPAP and a peripheral line in skin to skin contact. And you can see how the father has the other twin in skin to skin contact, and one of our nurses is keeping an eye on the monitors, securing the tubes or something there. And it looks really busy in the room, but I'm sure that the parents will not notice that. They're just happy together with their babies. How then in your NICU can you support skin to skin contact? Well, first, I think it's super important to define contraindications and to think about them, because if you want to, then of course ventilator care, CPAP care, umbilical lines, everything could be contraindications if you don't train and have routines and so forth. So I think you should also acknowledge the risks with any new intervention where you work. I think it's also important to make space. If you want the parents to do long hours of skin to skin contact, you need comfortable chairs or even beds for them to stay. As I said before, most mothers are patients too. So they will need the proper beds and comfortable chairs if they are supposed to do skin to skin contact for long hours. And you can see here some pictures showing what it looks like we have 3 NICUs, 3 Karolinska NICUs in Stockholm. So some different options of making space for the parents. In the upper picture, you can see an open bed with a bed for the parent next to it. And similar on the lower left picture, you can see the baby's bed there in the back, but the baby is actually not there, but in skin to skin contact with the mother. In the middle lower picture, you can see a twin pair sitting with the dad and the mother. So they have their twin bed, but they spend a lot of the time away from it in skin to skin contact with the parents. And you can see how we've arranged their CPAPs and monitors and made sure that all the tubes and lines reach from the machines to the chairs of the parents. And down to the right, you can see our new version of recliners that we use now for skin to skin contact at Karolinska. So these are the Kangaroo Mother Care chairs that we currently use. For the more stable infants, I think it's very helpful if you can provide carriers for the parents. So if parents are supposed to sleep with their babies in skin to skin contact, they need some kind of attachment in order for the skin to skin contact to be safe, for the baby to maintain a patent airway and not fall on the floor or anything like that, because these low birth weight or preterm babies, they will not protect their airway. So you need to make sure that you have safe skin to skin contact. For the well babies who don't need CPAP or lines, carriers can actually help the parents so that they can ambulate a bit in the unit also with their child, which is helpful, because then they will not be locked in the room because they want to do skin to skin contact. They can actually go get something to drink and move around a bit if you have good carriers. Most importantly, I think I said it before, but you should acknowledge that skin to skin contact in unstable infants immediately after birth. It's not easy. It's not something you should just start with without training. So if you consider, and I think we will consider, but if you want to start skin-to-skin contact with unstable babies immediately after birth, then please invite people with experience of this to your unit and train, because this is a special patient category when you need to think of well, placement of machines and their particular instability in order for the skin-to-skin contact to be safe. And practice makes perfect. So you need to train. You need to train your staff for them to deliver safe skin-to-skin contact for these infants. The parents will need support too. Most preemie parents have never been in a NICU before, so they will rely on you to tell them what to do. Eventually, and I think some of you in the audience may be parents of preemies too, and you will know that after a while you will want the skin-to-skin contact yourself. But in the beginning, I guess you really listen to the NICU doctors and nurses and you want the best for your child. And if the staff don't advise you to do skin-to-skin contact, then how would you know yourself from the beginning? So make sure that the parental support is there too. And I think my next slide shows a picture with a reference to a paper describing exactly this. So our colleague Siri Liljesköld has written a really nice qualitative study describing the experiences of parents who've had their low birth weight or preterm infants in immediate skin-to-skin contact after birth. And I think this is very interesting for you to read if you have parents in very early skin-to-skin contact. Siri, she defined 3 themes. So she found that the skin-to-skin contact was actually a pathway to connectedness. So it was a tool to get connected to your infant. And she also heard from the interviews that the parents described the situation as if they just were in a vulnerable state. They were vulnerable, it was scary, everything was new, but they were there and accepted the situation the way it was and appreciated it. And also the immediate skin-to-skin contact for a mother with health issues of her own, maybe pain after birth and everything that goes with having a preterm infant. Skin-to-skin contact sort of created the safe haven in an unknown terrain where everything was new. This paper also has some nice quotes from parents describing how important it is what we as NICU professionals say and what we advise them to do and what we believe in ourselves, because they will pick up all the nuances in how we talk about skin-to-skin contact immediately after birth and whether it's feasible or not, safe or not, etc. Yeah, and I think that's actually my last slide before we can have a discussion. So with this, I just want to thank you for inviting me to this talk, and I hope I brought up some of the things you were expecting to hear, but I think you will also have lots of questions because really my talk was just an introduction. So now, please, questions, comments.
Thank you so much. That was amazing. Amazing. I would like to ask Dr. Stina if you want to say anything. I know you've worked with Dr. Linnér. Can you unmute?
Hello, everybody.
Hi.
Hello.
Thank you, Agnes. Wonderful, wonderful presentation of our work and your work.
Thanks for all of your slides, Tina, because you recognize most of them.
I can see you're a really good photographer too.
Yeah.
Well, Actually, nothing really to add. I think you just did a wonderful job in presenting what we have been working on for quite a long time, and hopefully we will see an implementation of the actual immediate skin-to-skin contact for very preterm infants and above, sort of, so that we don't separate babies from their mothers when we don't really need to. That's sort of my professional goal of life to work for.
Yeah, and I agree with you, Stina, that we need to take steps. So at the moment, Stina and I are working with this sort of middle age, that sounds wrong, but 28 to 31 weekers, that age group, because we strongly believe that the benefits are huge for them and the risks are very small. So at the moment we are working on implementing, or we've just finished a study, but our goal is to implement immediate skin-to-skin contact and non-separation for this age group first, and then we will move on to the smaller ones later on. So I think that's the way to do it. Start at the end and then you move, and that way your staff will also gain experience and confidence to deliver safe skin-to-skin contact.
That's really a very important issue in this is staff confidence. Many times that's the barrier. And that's why they don't invite parents to sit skin to skin as soon as possible, or as immediate as possible, or whatever, because staff feel a bit insecure on how to do this. They were taught to do it to care for the babies in one way, and now we're coming here and saying that they need to do it in a skin to skin position with the baby. And they feel very blottad, Agnes.
Sort of exposed.
Exposed, yeah.
That's what you're looking for.
Mm.
I mean, they all really appreciate skin-to-skin contact, so don't misunderstand us that they don't want to deliver skin-to-skin. They just are not sure how to do it immediately after birth. And they've learned that they do their tasks with the infant in the incubator. So
we have our protocols, we follow them, we do a good job, we get the babies to survive, to have a good life, sort of to do all that. And we know how to do that. And we know what procedures we are expected to do. But then someone comes and say that we need to do them in another way. And that always feels a bit, we need time to adapt, I think.
We have a question from Matana731. Is it possible that you can unmute and ask your question?
Sorry, is it Nashwa? I'm not sure what I came up as. Is this about the bonding?
Yes.
Oh, hi.
Where are you from?
So I'm Nashwa Matta. I'm an associate specialist pediatric in Glasgow, and with an interest in infant mental health and development. Yes. So my question is, I see a lot of parents, because we talk constantly about skin to skin and bonding, they end up feeling quite worried that they are not bonding with their baby if they haven't had immediate skin to skin. So I always reassure them, we try to do it immediately, but sometimes the baby is very sick or you are very sick. So if you didn't have immediately skin to skin, there is a period you can build your attachment bond. So I have a concern about the overuse of word bonding everywhere, because I've met so many parents for years traumatized by this. I don't know how you feel.
I think Stina has a good answer, and I was about to say the same, but Stina, you go.
I can see this, how parents can feel guilt about not being able to do this and be able to have this skin-to-skin contact immediately and early. I would like to refer to the work from Ruth Feldman in Israel. She has studied the parental brain, and she saw that there are several ways to reach the same strong attachment and bonding. One is this immediate skin to skin, just normal birth, getting the baby up on your belly, and oxytocin is rising in your brain and your body, and you get this immediate response in both the mother and the baby. But there are other ways. So being involved in your baby's care, being there many hours, just watching your baby, caring for your baby, being involved in the care of your baby, talking about your baby, thinking about your baby. That makes your brain work, and you connect, and actually your brain develop. You get the parental brain, according to Ruth Feldman. And I think it's really interesting work that she's done. And it's on MRI scans. It's not a theory, it's fact, sort of, that this is happening in our parental brains. And there are many ways to get there. And you can get there with an adopted child, many years old, and you can get there.
I agree. Thank you so much. That's very important. It's just it comes from a lot of people who are not dealing with sick parents or sick babies, and it torments the parents. So that's an excellent. I will look up this research as well as a backup. Thank you so much.
Yeah, we will add them to the page of the recording.
Excellent. Thank you very much. Thank you.
And also there are so many other ways to involve the parents. So I think you shouldn't see it like it's dichotomous. It's either skin-to-skin contact or nothing. There are so many other ways to invite them. You have lots of nice pictures of that too, Stina, but parents who are next to a very sick child in an incubator, and how you can get them to connect anyway. So it's not skin-to-skin contact, but it's not only skin-to-skin contact or nothing. There are other ways.
I think the most important is to help the parents feel like parents in the NICU, that they are welcomed in the NICU, that they that they can come to the NICU and they be part of the team that takes care of them, instead of like we take care of them and then you just hear and bond with your baby. Like they have to be really being part of it. Like for example, for me, when Zachary was born at 28, the day after, the nurse asked me if I wanted to hold him, and I said no. But I said, why? I said, I don't want to hurt him anymore. I felt that I had hurt him enough to not being able to give him a healthy start. And he looked like, quiet and with all these tubes and all that. And the nurse told me, you will hurt him more if you don't hold him. So with that, it was like, okay, I am important for my baby, and I can, I can do things that nobody else can do. I am irreplaceable as the parent, and I am able to do many things for Zach, even just by holding or by being there and touching him and just cheering him up to make sure that he knows that I love him.
Absolutely.
So another question that I had was, you mentioned you had the aunt in one of your photos, in one of your cases. What is there a list of hierarchy? Like if the mom cannot do it, then the father, or can it be? Is there like a guideline of who could be there, especially now with COVID, that a lot of people are not allowed in? What do you recommend for that?
Yeah, so exactly what you said. So mother first, and if not the mother, then the father, and if not the father, then, well, the person the mother chooses actually. So in this case, in the picture, then the father was traveling for work, I think, and he couldn't make it home for the birth of his baby, and then the mother sister was there. So I think this is really setting dependent. In the immediate Kangaroo Mother Care study, it was controversial to have men in the NICUs, and then we used female relatives for skin-to-skin contact whenever the mother was not available. But in Sweden, yeah, the father will be the second one, or actually sometimes the first one. We use a lot of paternal skin-to-skin contact. We believe that the mother is the first option, but sometimes we struggle with the couplet care thing. So we often need to separate the mother and the infant in the beginning because of the mother needing obstetric care. And that's not the way we want it to be, but that's the way it is at the moment. So we have lots of fathers doing the immediate skin-to-skin contact.
I don't think I will ever do this study again, but if I would, I would change it. I would say mother infant skin-to-skin contact immediately from birth and continuously. I think that is the most important question, how the mother's body regulates the baby's body. The mother's body has been regulating the baby's body for as many months and weeks as the baby has been in utero. And the baby comes out, and we are physiologically programmed to continue to regulate our baby's body. And I think it is a difference with the father. I love fathers, I love men, but I think the mother is more important in this specific timing for the baby.
I agree. But any skin-to-skin contact is beneficial for the child, but you should really try hard to not separate the mother and the child, especially immediately after birth.
How long
also
is
for simple
session?
things like temperature, the mother is warmer also.
How long does it last from the birth and you place the baby on skin to skin to that session? How long is it? That the first session before.
Do you mean in our study?
Yes. Yeah.
In our study, it was 6 hours. That was the intervention period, but we wanted the parents to continue beyond the 6 hours, but the actual intervention period was 6 hours. But then you have the example, remember I showed you one slide with the baby boy Benjamin. They didn't stop, they just continued day after day. So it's individual, it's different from one family to the next.
And how do you prepare the parent or the mother, like when she needs to go to the restroom, like that? If that session is six hours, I feel you do something for them to keep them comfortable and being able to do that long session.
Well, one thing is the comfortable beds and chairs so that they can sit for a long time, but then also we advise them to eat and go to the bathroom and do those things first so that they don't have to interrupt the skin-to-skin contact because of that. But then, of course, they will need to come and go a bit, and we try then to change between the mother and the father, but sometimes we need to do intermittent skin-to-skin contact and intermittent incubator care.
And do they stay in the OR for those 6 hours?
In the operating room, if they stay there? No, they come to the NICU.
Oh, they come to the NICU. We have a question from Jake. It says we need to discuss, where did it go? HFOV and skin to skin. We continue to have barriers for these. We're working on the golden hour with our fetal health center, and skin to skin is one of these items on our agenda. So
I'm not sure if this is about extremely preterm infants on high frequency ventilation, or if it's term critically ill infants on high frequency ventilation. Because for us, we rarely have immediate skin to skin contact on high frequency ventilation for extremely preterm infants. We have later skin to skin contact with high frequency ventilation often. That's not a challenge at all for us.
What about
so
oscillator?
Later, sorry?
The oscillator ventilator.
Yeah. Yes.
Same.
So that's not a contraindication at all for us. We have lots of skin to skin contact with the oscillator.
But not from the beginning, from the birth of the baby. If the baby is so unstable, sick, so prematurely born that the baby needs the oscillator high frequency ventilation from the start, which we often use at Karolinska as actually primary ventilation mode for extremely really extremely preterm babies, the smallest preterm babies. We usually don't put the baby's skin to skin at that timing, but it's not a contraindicator later when the baby is sort of stable in high frequency oscillation ventilation in the unit.
So to summarize, I don't think it's the high frequency, the oscillation. I think it's not the ventilatory support per se, but it's the state of the child more than the equipment. That would be the contraindication in our settings. But then maybe we use HFOV maybe differently than in Jackie's settings, because as Tina says, it's our primary type of ventilation for the extremely preterm infants.
Just one comment, Agnes, didn't we reflect on during the study, we had a few cases where the baby was actually becoming ill and deteriorating during a skin-to-skin session, and nobody sort of, or we noticed it too late. It was just one or two babies, but we reflected then on that when the baby was sitting skin to skin with a parent, everybody sort of thought that the baby was stable and well. And this was a new setting. This was unstable babies. These were not stable and well. And in the unit, we sort of had the tradition, the culture, the view on babies sitting skin to skin that they were all well. So that's sort of a new way of working, new way of observing and monitoring babies in a skin to skin position that we need to talk more about, I think.
Yeah, definitely, because if skin-to-skin contact or kangaroo care has been used as a step-down way of care for stable infants, then of course many people will misunderstand when they see an infant in skin-to-skin contact. But this is why I'm saying that it's important to train and to talk about this as another type of skin-to-skin contact. It has completely different challenges than Kangaroo Mother Care as we knew it. So I completely agree with Stina that you can't really, you can't really take away nurses because you're doing skin-to-skin contact. Some people might say that, well, the parents are there, they can look after the child, but I think rather the opposite. You would need, in the beginning anyway, more nurses just to make sure that they keep an eye on the infant with all the new challenges to it. So it's a completely different type of patient.
Mm-hmm. And there you also have challenges with all the multidisciplinary team in the NICU, all the staff, not only nurses, but doctors and nurses and all the rest of them, of us, that we need to to work together with the parents and be very close to the parents, and it can feel a bit intimidating to be that close. We're sort of as our we are neonatologists, pediatricians. We work with the baby. We're not used to being really close to grown-ups and being close to their bodies and be that intimate sort of with the parents. So we need to cross the barrier there and not feel that, no, we need to leave them alone. They're sitting skin to skin. But we actually need to be there, to be close, to examine the baby skin to skin, to have these talks with the parents and reflective sessions and examinations of the baby there in skin to skin.
And the parents, they see that too. This is described in this reference by Siri Liljesköld, how if we leave the unstable, brand new infant in skin-to-skin contact with the parent, they will feel left alone if we're not there monitoring the child. So, yes.
Yes, especially if they're little and, you know, for like you mentioned, and it was the same for me, it was the first time that I ever knew that the NICU existed. And from the time that I knew that I could have a preemie to that time that I had a preemie was 2.5 hours. So I was totally unprepared. And so the staff giving support to the parents is really important. And to make sure that, you know, parents are there to help and to take care of this baby, but they are very qualified individuals that are, you know, they are taking care of the baby of us, obviously. So yeah, that's incredible. Definitely. It's now one of the questions that I had, I know you guys do in Sweden 24-hour kangaroo care, or can you tell me a little bit more about that? It's it like here we are, you know, a couple of hours in kangaroo care and the rest on the bed. I think you do it the other way. You know,
we wish we did.
Tell me a little bit more about it, because, you know, we talk about Sweden and how you guys are, you know, really the leaders on kangaroo care and how long you guys do it. So can you talk a little bit about that?
I wish we did 24 hours. In the same study where I looked at the initiation times, I also looked at daily durations of skin-to-skin contact, and I think the numbers are a bit low, that there is some under-reporting actually, but according to our quality register, we do about 5 hours per day for very preterm infants. I think it's not completely there, but it's in that range.
That's
maybe.
A lot.
Do you think? Yeah, it's less than 24 hours.
I did 5 hours 21 years ago.
Yeah.
But it was, you know, I was Colombian and I knew it, and I had, you know, the staff that supported me and all that. But we stopped kangaroo care early. We didn't go to the 3 months after due date, like, you know, we are recommending now. Do you recommend these moms that go home to continue kangaroo care? And do you support them?
Yes.
Yeah, that's fantastic.
So we advise them to have carriers if that's helpful for them, to be ambulating a bit at home. And we say that the infant will tell when it's time to stop.
Right, yes. They start moving.
Wriggling.
Wriggling. Thank you. Any last comments, any last ideas or suggestions for everyone that is listening?
I just want to say that a really important thing is to advocate for parents being able to actually stay in the unit 24/7, and then you can increase the time to just be with your baby and also to sit skin to skin. But if you're not there, if you have to stay to sleep at home, to go home to your house or apartment every night to sleep, things become much more complicated and difficult, and you will have barriers for increasing the time in skin to skin. So that's sort of why I think Sweden might be looked as a sort of a gold standard. We don't have 24/7 skin to skin, but we do have 24/7 parents being in the unit and having parental leave. So there are actual benefits and help for us to keep on the strive for increasing the time that the baby can actually be in skin to skin.
So for your very preterm babies, it's about 5 hours. What about like a 32-weeker? How long would they be in kangaroo care on average?
That's also very different from one family to the other. I would say that they sit in skin to skin contact maybe some hours in the morning, some hours in the afternoon, and then some hours at night. So sort of 3 sessions. It's different, but that's some sort of general observation. We have a system in our NICU that we do the rounds together with the parents, and that's a good thing and a bad thing, because some parents, they are a bit restless in the morning. They don't want to miss the rounds, so they wait for the doctor to come and do the rounds, and usually then they don't do skin to skin contact during that time because they want to come sit by the computer to discuss the medical things. It's a bit odd, I think, that we can't go to the parents. In some of our NICUs we go to the parent, and in some of the NICUs we ask them to come to our nursing station for the rounds. So that's where they miss a couple of hours of skin to skin contact because of that. But then I think they do a couple of hours before lunch, after lunch, and in the evening. And I think many of the parents, they really appreciate the evening session because it's a bit more calm in the unit. The rounds are over and not so many procedures, and it's a high quality time for them, I think. And now I'm talking about the intensive care and skin to skin contact in the family rooms. Then I think it's different.
We did have we have had several at Karolinska and in many other units. We have had several periods of counting skin to skin contact, and last time we checked that, it was a mean time of 8.5 hours per day per 24 hours.
That's a lot. That's good. That's great. Well, thank you so very much to everyone that came and that is listening to this session. I want to thank Dr. Agnes and Dr. Stina for joining us and talking about this amazing topic. I want to invite you for the next one, which is next Wednesday, and it's going to be with Dr. Dorothy Bittner. She is from here, from the US, and I have followed her forever for her research on skin to skin. So she's going to talk about the neurobiological influences of skin to skin contact. So thank you so much. I'm going to stop the recording now.